Today, we're peeling back the layers on really one of the most critical, yet maybe least discussed systemic changes happening right now in U.S. healthcare.
Yeah, it's a big one.
This isn't just about, a new form or some minor rule change. We're talking about a fundamental overhaul of how we pay for and ultimately how we monitor maternal health.
Absolutely. It impacts billions of dollars in claims every year. It dictates clinical workflow. And maybe most importantly, it holds a key to improving some really concerning maternal morbidity rates.
We are talking about the dismantling of the global OB care package.
That's right, that single lump sum payment that's governed how obstetricians and gynecologists, OBGYNs, get compensated for pregnancy care for, decades.
And that model, the global package, it's been the standard for so long. It was set up to cover basically everything, right? All the routine prenatal visits, the delivery itself, and then the routine postpartum care.
All bundled into one payment.
But it's clearly breaking down. And this payment reform, it's being driven pretty aggressively by professional bodies like ACOG, that's the American College of Obstetricians and Gynecologists, and we're seeing it rapidly adopted by large state Medicaid programs.
Yeah, the thing is, the global CAID is fundamentally a product of the 1980s.
Right.
And back then, pregnancy care was, it was viewed as a relatively standardized clinical journey. The whole idea was to create administrative simplicity. Pay one rate, cover the whole 9 months, basically.
But healthcare today, especially maternity care, it's anything but simple or standardized. So if the system is designed for an environment that, basically stopped existing 40 years ago, what happens?
Well, the system fails. It fails to reflect modern clinical complexity. It creates this massive disconnect between the actual effort a provider puts in and the compensation they receive. It just can't account for the rising tide of high-risk pregnancies we're seeing, or all the essential complex services that providers routinely deliver now.
Okay, so our mission in this deep dive is, let's say, threefold. First, we need to really unpack the critical reasons driving this huge change. Why did the global code fail so badly?
Yeah, what broke?
Second, we'll break down the new capabilities. What's being introduced by this unbundled billing approach and some of these alternative payment models.
Getting into the nuts and bolts.
And finally, we need to analyze the major implications. What does this mean for provider compensation, for administrative burden, and crucially, for patient safety and the quality of the data we get? Because this shift, it's not theoretical. It's happening right now, and you really need to know how it works.
Definitely.
All right, let's start by laying out the case against the global package. The core problem, as ACOG puts it, is that this payment system treated care as just a lump.
Yeah, a single lump sum.
And that created some deep structural flaws, particularly when it comes to data, right?
Precisely. That simplicity, the lump sum, it became its biggest weakness. Because you just received one code for the entire episode of care. It was, impossible to discern the granularity of that care. The Iowa Health and Human Services Department, when they announced their move to Unbundle, they explicitly stated that it was impossible to identify quality data within the bundled system.
And why does that granularity matter so much? If I, as a payer, just get one bill for 9 months of work, I know a delivery happened, but what else?
Exactly. You don't know the journey. You don't know when key interventions happened, or even if they happened at all. Did the patient get the right screenings at the right time? Was there early intervention for a developing issue?
You just don't see it in the data.
That lack of granularity just completely hinders quality monitoring, period.
Yeah.
If you can't see the individual visits, the screenings, the educational components, you can't measure performance effectively.
Right.
You can't implement good population health strategies, and you certainly can't benchmark quality between different practices.
And for the provider, did it really simplify things?
Well, that's the irony. The administrative complexity wasn't actually removed. It was just sort of delayed and amplified. If there was any mistake, any wrong accounting of data, as the source put it, on that single massive claim covering months of care,
The whole thing could get kicked back.
the entire claim could be rejected or denied. And that leads to this immense financial burden and, frankly, cash flow instability for the practice. It's a huge risk.
Okay, so the structure itself was flawed, and that flaw gets magnified when you consider how much pregnancy care itself has changed since the 80s. Modern care is just It's more complex. It needs more resources.
Absolutely. That increasing complexity is undeniable. We've seen a measurable rise in the proportion of births to women aged 35 and over.
I saw that statistic.
Yeah, that demographic went from roughly, 11% back in 2000 to approximately 15% by 2020. And that shift is clinically significant because advanced maternal age is associated with higher risks, things like preeclampsia, gestational diabetes.
Things that require more careful monitoring, more visits maybe.
Definitely more intensive monitoring. The standard approach, the global payment, simply doesn't cover the time and resources needed for that.
And then you layer on the Medicaid population, which, they represent the majority of births in many states. The risk factors there often stack up even higher, right? Compounding the need for more granular, high-resource care.
Correct. The population served by Medicaid often presents with a higher prevalence of chronic health conditions, obesity, pre-existing diabetes, hypertension. These are common.
Right.
And beyond just the clinical conditions, they frequently face significant socioeconomic barriers. Things like food insecurity, housing instability, or maybe co-occurring substance use disorders.
Which takes time and coordination to manage.
A lot of time. Managing these social determinants of health is absolutely crucial for a positive outcome, but it demands coordination, time, specialized screening, all things the 1980s global system completely failed to recognize or fund.
So the only real difference the global system recognized was vaginal versus C-section.
Pretty much. That was the main differentiator for reimbursement. It almost entirely ignored the full spectrum of clinical and socioeconomic complexity that happens during the pregnancy before delivery even occurs.
It feels like the whole global package was built on this idea that, 95% of pregnancies are low risk, straightforward, and the occasional high-risk outlier could just be absorbed financially.
That seems to be the underlying assumption.
But if the baseline complexity is rising across the board, if 15% are already older and many more have chronic issues or social needs, that absorption model just becomes financially impossible for practices.
That's exactly the crux of it. And this leads directly to the second major failure point we need to talk about.
Yeah.
The code itself undervalues or completely ignores modern evidence-based services that are now standard practice.
Things that didn't really exist or weren't common back in the 80s.
Exactly. When the global code was established, nobody was billing for telehealth routinely. Nobody was consistently screening for mental health issues as part of prenatal care.
So what are some of the specific services that were just getting swallowed up by that lump sum? The things that resulted in underpayment and, as you said, resource restriction.
Oh, there are several critical ones. Telehealth and home monitoring services are huge now, especially post-pandemic, for reaching patients in rural areas, those maternal care deserts.
Right. Access is key.
Then there's enhanced postpartum monitoring. This is essential for catching dangerous complications like postpartum hemorrhage early.
Which the global feed didn't really incentivize.
Not adequately. And crucially, the code didn't properly account for mental health and behavioral health screenings, which are now seen as mandatory for holistic maternal care.
Can't separate physical and mental health.
You shouldn't. We also have essential preventative services like genetic counseling, detailed social needs screenings, figuring out if someone has stable housing or food, and the resource-intensive process of running group prenatal care models.
So if a provider is, say, mandated by quality guidelines or state rules to do a mental health screening, but the billing system basically says, nope, you already got paid for that 9 months ago in a lump sum, where does that money come from?
It has to come from somewhere else in the practice's budget. Effectively, the provider ends up subsidizing comprehensive care if these services are underpaid or completely unpaid.
Which isn't sustainable.
Not at all. And the source material is really clear here. This lack of adequate compensation leads directly to financial hardship. That restricts resource allocation, it contributes to physician burnout, and it literally drives the closure of OB/GYN services.
Especially hitting those vulnerable, rural, and low-income areas hardest.
Precisely. ACOG's argument is straightforward. Moving to equitable pay for complex care isn't just about the provider's bottom line. It's essential for attracting and retaining qualified practitioners to ensure we have continued access to comprehensive women's health care across the country.
Okay, so the old structure is, well, functionally and financially bankrupt, it sounds like. Now let's make the shift. Let's talk about the new structure. This is where unbundling really comes into sharp focus. How is ACOG leading this strategic shift towards more granular compensation?
ACOG's strategy is really designed around precision. They're moving away from that single global code to create payment modules that can actually capture the diversity and the complexity of the care being delivered.
So instead of absorbing everything.
They're bundling out specific high-value services. So, for example, they're advocating for separate payments for things like comprehensive genetic counseling, or those specialized social needs screenings we mentioned, or even the resource overhead required for running successful group prenatal care sessions. These things take time and staff.
This sounds like a massive shift in documentation requirements, though. If I'm a provider, I can't just chart, prenatal visit. I have to document every specific service rendered and use much more granular codes.
That is definitely the trade-off. Transparency requires more labor, more documentation. ACOG is pushing for using complexity modifiers with existing CPT codes. Current procedural terminology codes.
Modifiers.
Yeah, these are little additions to the code that signal extra complexity. They help reflect the intricate nature of managing both the mother and the fetus simultaneously, which often happens in high-risk cases.
Okay.
Furthermore, they're promoting the appropriate use of inpatient evaluation and management codes, EM codes. These are codes like 99222, 99232. They're meant for situations like very long labor hours, or when you have to bring in multidisciplinary specialists, maybe a cardiologist or an endocrinologist during the delivery stay.
Costs that were previously just invisible inside that global package?
Exactly. They were just absorbed, often at a loss.
And they're also stressing separate billing for distinct high-cost conditions, I gather.
Absolutely. Things like postpartum hemorrhage, which requires immediate, intensive, and often expensive care, or specific contraceptive techniques that might be initiated right after delivery. These need to be billed separately.
Why is that so important?
It ensures that the provider is actually compensated for the real clinical effort involved in managing complications, instead of being financially penalized for taking on a patient who develops a high-risk issue. It aligns payment with the actual work.
Okay, let's look at a real-world blueprint for how this unbundled model actually works in practice. Iowa Medicaid seems like a key example here, mandating this change for their primary members starting October 1st, 2025. This really shows us the future of how maternity care might be billed, transaction by transaction.
Yeah, Iowa's model is pretty comprehensive. It completely removes the global OB payment option for their Medicaid population, where Medicaid is the primary payer. And the most fundamental change is right there in the antepartum visits.
The regular checkups.
Right. Instead of waiting months for one lump sum after delivery, providers now submit claims for each visit. They get reimbursed per visit using standard medical EM codes.
EM codes. These are the bread and butter codes every doctor uses for an office visit, basically. The general currency of medicine.
That's right. They're using codes like 99203 or 99213, which are typically used for established or new patient visits of moderate complexity. But here's a key detail. They also require the use of the TH modifier.
TH modifier, what does that signal?
The TH modifier basically tells the payer that this service, while coded as a standard EM visit, was provided as part of a necessary comprehensive treatment program, in this case, maternity care.
So it flags it as part of the overall pregnancy episode.
Exactly. It helps payers recognize that context, even though it's being billed individually.
So the provider gets paid incrementally after each visit. That must significantly improve cash flow compared to waiting for one big check.
Huge difference for cash flow.
But how do they prevent overutilization? If I get paid per visit, what stops a provider from just scheduling patients constantly?
That's where the state sets some boundaries. Iowa Medicaid has allowed up to 14 standard antepartum visits without needing prior authorization.
14 visits.
Which is a pretty practical cap. It covers a typical pregnancy schedule, even one that's slightly extended. Now, if a patient truly requires more than 14 visits due to complex risks, the provider then has to seek specific authorization.
Okay, so there's still oversight.
Right. It maintains clinical oversight while managing the financial risk for the payer. And they also stipulated that the very initial prenatal visit must be in person.
Why in person for the first one?
To ensure a comprehensive physical exam and detailed history are established right at the beginning of care. Telehealth can be used later, but that foundational visit needs to be face-to-face.
That makes sense. Okay, so we're moving from one big financial event to this series of individually billed, documented clinical interactions for prenatal care. What about the actual hospital stay for delivery?
That inpatient care component is also completely restructured. Instead of those costs being hidden, specific codes are now used for any hospitalizations that might happen during the pregnancy for complications, or for the direct post-delivery care while still in the hospital.
So separate billing if someone needs to be admitted early for preeclampsia, for example.
Exactly. We see the use of those inpatient EM codes, again, like 99222 for the initial hospital care day, 99232 for subsequent days, and 99238 for discharge services. These codes allow for detailed reimbursement based on the actual time and complexity of the physician's work during that hospital stay.
Something the global package just couldn't capture.
Not at all.
And the delivery itself, that also becomes its own distinct billable event.
Yes. They shift to using delivery-only codes. There's 59409 for a vaginal delivery and 59514 for a C-section. Pretty straightforward.
Okay. And postpartum care. That used to be just sort of rolled into the global fee, often just one quick visit at 6 weeks.
Right, often rushed and undervalued. Now it's itemized using code 59430 for per-visit reimbursement. And notably, Iowa Medicaid is actively encouraging 3 postpartum visits during the full 12-month benefit period after delivery.
3 visits over 12 months, that's a big change.
It reflects the growing clinical understanding that the 4th trimester, that postpartum year, requires sustained support, especially for high-risk patients. It's not just about checking stitches at 6 weeks.
Okay, this unbundling shift is massive for payment accuracy and cash flow. But let's talk about the administrative enforcement mechanism that really drives data transparency, the F-code mandate. You called this the aha moment. Why? Because it demands data, even when it doesn't offer direct payment.
This is, I think, the really clever part of the policy reform. If unbundling is about getting the payment right, the F-code mandate is about guaranteeing the data quality. States like North Carolina and Colorado are mandating the use of CPT Category 2 codes. These are known as F-codes, and they have to be submitted alongside the delivery codes.
CPT Category 2 codes, what makes them different from regular CPT codes?
They are specifically performance measure codes. Their only purpose is to track clinical data elements relevant to quality measurement and outcomes research. And here's the kicker. They are non-reimbursable.
Non-reimbursable.
Yeah.
So providers bill them for $0.
Exactly. They're billed with a $0 charge. Sometimes EHR systems require some value, so it might be a penny charge, but the provider gets no money for submitting them. They exist purely for data collection.
Okay, so the provider has to do extra administrative work, extra documentation, essentially for free. That sounds like a really tough sell. Why would they possibly comply?
Because compliance is becoming a non-negotiable prerequisite for getting paid at all for the really expensive part, the delivery itself.
There's the leverage.
Huge leverage. There are 2 key F codes we need to know here. 0500F, which signifies the initial prenatal care visit, and 0503F, which signifies the comprehensive postpartum care visit. And North Carolina Medicaid is enforcing this strictly. After July 1st, 2025, delivery claims, even if a payer still somehow allows a traditional global package, will be flat out denied if that 0500F code isn't on the claim.
Wow, denied. So if a provider fails to electronically document when that initial prenatal care started the timing of care, they literally don't get paid for the delivery that might happen months later.
That's exactly right. It forces the entire system, providers and payers, to align with national quality measures like the 80s prenatal and postpartum care PPC measure, which absolutely rely on having robust, standardized data points about timing.
So the F codes provide that granular data on the timing and the occurrence of these critical care touchpoints data that the single global code completely hit.
Precisely. Even if a patient presents late to care, maybe in the 3rd trimester, the system is designed to force the delivering provider to use that 0500F code to establish some point of data capture for when care began, however late. It creates a data point where none existed.
Okay, so unbundling gives us transactional clarity, F codes give us quality enforcement through data, but the future of payment is often talked about as value-based care. That brings us to the alternative payment models, or APMs, that the source material highlighted.
Right, APMs represent the next step, moving beyond simple fee-for-service, even unbundled fee-for-service, toward models that try to incentivize good outcomes and efficient use of resources. They can be complex, but they offer potential solutions, especially for managing high-risk populations that even straightforward unbundling might not fully address.
Let's break down the 3 main types mentioned in the sources. First up, pay for performance. Sounds straightforward.
Pay for performance, P4P, is probably the simplest model conceptually. It keeps the underlying fee-for-service structure. The provider still gets paid for each visit, the delivery, etc. but it adds bonus payments on top if they meet specific clinical outcome metrics.
Like what kind of metrics?
For instance, Connecticut and Colorado use P4P models that might reward providers who achieve high rates of postpartum visit attendance within, say, 21 days of delivery. Or maybe maintain low evidence-based C-section rates for low-risk patients. It's basically a financial nudge toward quality without fundamentally changing the billing structure.
Okay, a bonus for hitting targets. Then you have the model that sounds riskier, episodes of care.
Episodes of care, EOC, is definitely a step up in complexity and risk. This model treats the entire pregnancy, delivery, and postpartum period as one single financial unit, often measured against a benchmark cost.
A budget for the whole pregnancy.
Essentially, yes. The payer sets a target budget for the entire clinical episode. If the provider manages the patient efficiently and keeps the total cost below that benchmark while still maintaining quality, that's key. They get to share in the savings. That's the upside risk, the potential reward.
But the flip side, the financial risk here sounds very real.
It absolutely is.
Yeah.
EOCs typically also carry downside risk. If the costs may be due to unexpected complications or just higher than average utilization end up exceeding the benchmark budget, the provider might actually have to pay money back to the payer or face some kind of penalty. Yeah. And because of this inherent financial risk tied to unpredictable complications, EOC models like the one Arkansas used for a while or Connecticut's Ushki maternity bundle are often limited primarily to low-risk cases. High-risk pregnancies are just too clinically volatile to budget for effectively under this kind of model.
That sounds like it creates a major barrier then for providers who serve those high-risk Medicaid populations we talked about earlier. If EOCs avoid them, how do we incentivize better care for them? That leads to the third model, the pregnancy medical home.
Exactly. The pregnancy medical homes, PMH model, which North Carolina uses notably, is designed specifically to address that gap. A PMH provides a supplemental payment. Think of it as a care coordination fee that gets paid on top of the standard fee-for-service payments, whether global or unbundled.
A supplemental payment just for coordination.
Yes, and it's specifically designed to cover the extra overhead involved in coordinating complex, person-centered care. It's often focused on addressing those social determinants of health, connecting patients with resources, intensive follow-up.
So this extra payment isn't just padding the bill, it's actually funding dedicated staff or resources.
Precisely. It helps fund the necessary resources like social workers, care managers, patient navigators, the people who actually do the work of coordinating transportation, addressing housing or food insecurity, following up on behavioral health referrals.
And the key difference from EOCs.
Crucially, the PMH model allows practices to take care of high-risk populations without placing that significant, often unmanageable downside financial risk onto the provider for costly but clinically unavoidable complications. It effectively separates the financial risk of coordination failure, which the PMH payment addresses, from the risk of clinical complication, which is covered by fee-for-service.
Okay, this whole shift, unbundling, F-codes, APMs, it clearly offers benefits for data quality and maybe more equitable compensation. But it also sounds like it creates immense administrative overhead. Let's talk about the practical implications for providers who have to operate in this new, fragmented billing environment.
Yeah, the immediate challenge is definitely payer complexity. The administrative trade-off for getting all this transparency is significant. We are now essentially in a mandatory bifurcated billing world for many practices.
Bifurcated, meaning split.
Split, because most commercial payers, your Cignas, your Blue Cross Blue Shields, they often lag behind. They might still be retaining the old global model for their members. Meanwhile, the state Medicaid programs are rapidly shifting to required unbundled fee-for-service, or these complex APMs like PMHs.
So a single OBGYN practice has to run two completely different billing systems for the exact same clinical service, depending only on which insurance card the patient hands them.
That's the reality. It requires incredibly meticulous coverage verification for every single patient encounter, and it demands a really high level of expertise from the billing staff.
They need specialized training.
Absolutely. They have to be trained on the correct use of all these granular CPT codes, all the modifiers like modifier 25 for every possible scenario.
Modifier 25, that's the one that signals a separate significant service during the same visit, right? Can you give a concrete example of when a provider needs that during a routine pregnancy visit under unbundling?
Sure. Let's say a patient comes in for their scheduled prenatal checkup, which, under the unbundled model, is billed using, say, a 99213 EM code. But during that same visit, the provider identifies and deals with an unrelated, significant problem. Maybe there's a suspicious mole that needs an immediate biopsy, or an abnormal lab result comes back, requiring distinct counseling and a new prescription right then and there.
Okay.
That procedure, or that separate evaluation and management for the new problem, has to be documented thoroughly and billed separately. And you have to put modifier 25 on the basic EM visit code, the 99213, to signal to the payer that the visit itself was significant and separately identifiable from the procedure or the other problem management.
And if you forget the modifier?
The claim for the procedure or the extra work is likely to be denied, bundled back into the basic visit payment. It's a minefield. The administrative burden is just massive. It requires robust documentation for every single encounter, and it definitely increases the practice's exposure to audits.
That complexity sounds exhausting, and I wonder, doesn't this heavy documentation load potentially deter smaller, perhaps rural practices that might not have a huge billing department? Could it inadvertently undercut the goal of maintaining access in those maternal care deserts we mentioned?
That is the necessary critical question, isn't it? While the clear intent is to compensate complexity fairly, the sheer administrative overhead of using all these codes correctly, inpatient EM codes like 9922 or 99232 for complications, tracking potentially 3 different postpartum visit codes, managing 2 completely different payer rule sets side by side, it undeniably creates a barrier.
It takes resources.
It requires substantial investment in staff training, maybe new IT infrastructure or billing software, and rejecting claims due to coding errors, even seemingly minor ones, remain a major threat to the practice's financial health, regardless of whether it's a bundled or unbundled model. It feels like it trades the risk of one big denial for the risk of many small, complex compliance failures.
Okay, let's pivot from the financial and administrative risks to maybe the most severe implication, which goes beyond dollars and cents: patient safety. The source material here was extremely sobering, directly linking the lack of transparency from the old global code to fragmented care and, frankly, lethal consequences.
Yes, this is where the data really demands our full attention. The sources talk about fragmentation of care. Clinically, that's defined as a patient being readmitted to a different hospital within, say, 60 days postpartum than the one where they actually delivered their baby.
Okay, readmitted somewhere else.
And the data, looking back from 2010 to 2014, showed that over 15% more than 1 in 7 of all 60-day postpartum readmissions were fragmented like this.
15%. Why is being readmitted to a different hospital such a significant risk factor?
Because that readmitting hospital, being separate from the delivery hospital, often lacks critical medical information needed to treat the postpartum complication effectively. They might not have detailed records of the patient's prenatal course, any nuances of delivery complications, or the patient's ongoing high-risk status.
Information that was often obscured or just not readily available in the old system's single lump sum billing record.
Exactly, that vital context is missing.
And the outcomes associated with this data void, this fragmentation, are, well, they're terrifying.
They really are. The analysis showed that fragmentation was associated with 1.81 times the adjusted risk ratio for severe maternal morbidity.
Nearly double the risk of a life-threatening complication.
Just let that sink in.
Yeah.
Nearly double the risk. Furthermore, fragmentation drastically increased costs. The mean hospitalization costs jumped from about $5,700 for non-fragmented postpartum care to nearly $8,500 for fragmented care.
Wow, almost 50% more expensive.
Almost 50% higher cost, alongside a significantly increased risk of a prolonged length of stay in the hospital, and critically, a much higher maternal mortality risk. The study found a risk ratio of 3.27 for maternal death associated with fragmented care.
3 times the risk of dying. It's just stark evidence that a lack of coordination, fueled by a lack of data transparency, kills and costs. The system wasn't just losing data points, it was actively putting patients at risk because it failed to support coordinated, continuous care.
And here's the really critical socioeconomic layer to this. Public insurance status, specifically having Medicare or Medicaid, was associated with the largest effect in increased risk for this dangerous fragmentation compared to having private insurance.
Really? How much higher?
The adjusted risk ratio for fragmentation was 1.28 for Medicaid patients, and even higher, 1.68 for Medicare patients, compared to those with private insurance.
So the populations who are often already the most vulnerable, dealing with chronic conditions, socioeconomic barriers, the very populations the PMH model is trying to help, are also the most likely to experience this dangerous, fragmented, high-cost failure of care coordination.
That's exactly what the data suggests. And this, I think, is the profound underlying implication of this whole payment reform push. The shifts to unbundled billing, and particularly that F-code mandate, it isn't just about financial clarity or administrative neatness. It is a direct, potentially life-saving intervention aimed squarely at closing this dangerous data gap.
By forcing the system to record the timing and occurrence?
A prenatal and postpartum care via those F-codes, policymakers are essentially demanding the data necessary to improve safety and coordinate care transitions better, especially for the populations who are currently suffering the worst outcomes from fragmentation.
Okay. Finally, just bringing it back to the practice level, how does this shift to unbundling change the day-to-day financial flow? We touched on cash flow earlier.
Yeah, it fundamentally revolutionizes the revenue cycle for OB practices. Instead of waiting, sometimes months, for one massive payment, which, as we said, was always subject to potentially catastrophic denial practices, now receives smaller incremental payments throughout the pregnancy journey.
Payment follows service more closely.
Much more closely. This stabilizes cash flow dramatically and aligns revenue directly with the service delivery timeline. It moves practices away from relying on that single huge lump sum that might be delayed or denied for reasons completely unrelated to the bulk of the care provided.
And that stability matters.
That incremental revenue stability is absolutely crucial for attracting and retaining qualified practitioners, for addressing physician burnout because financial stress is a major contributor, and ultimately for ensuring that high-quality, complex maternal care is finally compensated appropriately. That's a feat the 1980s global code was simply incapable of achieving.
So wrapping this up, this deep dive has really revealed that the big move away from the global OB package is, well, it's painful, it's complex administratively, but it seems absolutely necessary. It's a reaction to rising maternal risk and this desperate need for better, actionable data.
Yeah, we've seen this new landscape emerge. It's a sophisticated mix, really. You've got transactional clarity coming from the granular per-service billing with EM codes.
Yeah.
You've got potentially better financial stability from the modified cash flow.
Right.
And crucially, you have this quality enforcement mechanism through those mandatory non-reimbursable F-codes. Those F-codes, acting as required data markers, they are the lever that states are now using to force transparency into a system where it just didn't exist before.
It really is all about making the complexity visible. Visible for proper payment, yes, but maybe even more importantly, visible for patient safety. But let me leave you, our listener, with one final provocative thought, building on those really severe consequences of fragmented care we discussed. We established that the source material clearly links public insurance status, Medicaid, Medicare, to a significantly increased risk of fragmented postpartum care and subsequent severe morbidity, even death. So if these payment reforms, the unbundling, the F-codes, if they successfully generate the detailed granular data they're designed to, showing who got care when. Should the next inevitable policy step be to specifically mandate improved electronic health information sharing and verifiable coordinated transitions of care using that newly available data as a strict prerequisite for all reimbursement, especially focusing on those high-risk publicly insured populations who are suffering the most from these coordination failures right now?
That is the essential policy challenge, isn't it? Data collection is really only the first phase. If we know definitively the fragmentation is tied to triple the maternal mortality risk, and we now have the data points via F-codes to track when and if key care occurred.
Yeah.
Perhaps payment needs to move beyond simply tracking that data.
So incentivizing action.
To actually penalizing the failure to share that data effectively, or the failure to coordinate based on that data, particularly in that critical postpartum period. Maybe the payment system itself has to become the ultimate enforcer, not just of data submission, but of actual care coordination.
A compelling challenge for how payment reform might directly drive safety policy in the future. Thank you for taking this deep dive with us today.
Always a pleasure. Thanks for the discussion.
Look out for new updates.